Welcome to part three of our three-part roundtable discussion on the current topics in Parkinson's disease. I'm Dr. Winston Wong, formerly from the payer arena and currently an independent consultant, and I will be moderating the roundtable discussion. The goal of this multidisciplinary roundtable is to review Parkinson's disease treatment options, management challenges, and reimbursement considerations from a physician, payer, and pharmacist perspective. For this series, we are joined by the following experts. Dr. Yasser Torres Yagi is the director of the Parkinsonism and Dementia Clinic at the MedStar Georgetown University Hospital. He's also the co-director of the Movement Disorders Fellowship at the Parkinson's Foundation's Center of Excellence and an assistant professor of neurology at the Georgetown University School of Medicine. Dr. Yagi will be representing the physician perspective. Dr. Patty Today Allen is the VP of Clinical Programs and Services at Welldyne. Dr. Today Allen will be representing the pharmacist perspective. Dr. Barney Spivak will be representing the payer perspective. On the screen, you will see the disclaimer and faculty disclosures for this activity. Part three of our discussion today will review our current understanding of Parkinson's disease and the goals of treatment as it pertains to the treatment paradigm and reimbursement issues. So let's start off with a question that we all know in terms of the epidemiology of the disease. As the percentage of older adults in America grows and becomes eligible for Medicare, what are some of the concerns for these patients with Parkinson's disease, as well as for the overall healthcare system? Dr. Spivak?
Yeah, I think from a health system perspective, obviously, as the population is growing of older adults, one of the main challenges is going to be and is managing cost. In other words, managing the need for effective therapies, not only for Parkinson's disease, but for all of the other conditions that we're trying to manage, and to try to utilize the therapeutic options that we have most effectively. In other words, to try to provide the highest value pharmaceuticals and other approaches to managing this growing population. We want to try to avoid, if we can, the need to institutionalize older adults. Again, significant costs involved with that. And if we can avoid the need for that care in an institutional setting and ensure that those who have Parkinson's disease can continue to manage, if possible, at home, in the community, with their loved ones, with caregivers who can manage things as effectively as possible, that will have improved not only our financial system, but also, I think, improve the lives of those older adults. And often what this means is providing greater support to the caregivers. In other words, not only financial support, but enabling better community management approaches to deal with the day-to-day needs of these individuals, whether it's adult daycare, whether it's improved home and community care approaches, whether it's improved rehab approaches that can be fostered within the community, improved education, and so on. There's a lot that could be done to try to better support the care of these older adults, not only for their Parkinsonism, but for how they are going to be able to manage best, given all of the other what's called multimorbidity that exists in many older adults. In other words, managing multiple chronic conditions or chronic problems concurrently. Very difficult to manage heart failure, diabetes, peripheral arterial disease, chronic obstructive lung disease, neuropathy, stroke, and Parkinson's disease in that one individual. We talk about medication burden or medication management burden. Just think of how many different medications may need to be utilized that are demonstrated to be effective for managing the multitude of problems that many older adults typically present with. So again, we haven't talked as much about, I think, some of the psychological, psychiatric problems that those who have Parkinson's disease can manifest. But very common to have depression, very common to have, as Dr. Yagi mentioned, anxiety, very common to have adjustment disorders due to the disability that occurs as a result of Parkinson's disease. These are all going to increase. And the more that we can do to plan effectively to grow the older adult care team, in other words, those health professionals that are focused on, knowledgeable, and shown to be effective in the care of older adults, the more that we can do to build that base of the workforce, the better we will be prepared as a society, I think, to better manage not only Parkinson's disease, but the increasing burden of multiple chronic conditions that exist in this population.
But I'll add to that. When I talk to pharmacy students, I tell them we need more board certified geriatric pharmacists in the United States, especially as we're going to see a 60% increase in the number of elderly individuals. And so we need these care teams, but we don't have enough of them. We don't have enough pharmacists that are really trained in geriatric medicine and really understanding how, when we're looking at the elderly population, it's not, they don't metabolize the drugs the same way that we learned, as we became pharmacists, right? It takes in that additional kind of specialization and certification. So, I tell my students, if you want to have job security, look into geriatrics and also look into specialty, disease states or specialty pharmacy, or both, right? And so I think it's really important to also understand that there is a shortage of these experts necessarily in these fields, that we need to make sure we tell the current students that are currently in either med school or in pharmacy school that this is definitely something that is going to be a dramatic need for in the coming 10 to 20 years.
Well, the need is now. Again,
that's true.
There's clearly an identified need to improve and enrich the geriatric workforce. There's no question about it. And many of the professional organizations, the American Geriatric Society among them, have taken a lead in trying to grow that. Again, it's a lot of public policy, it's a lot of advocacy and education of the public, as well as our legislators, in terms of what really needs to happen to best manage the older adult population who is on Medicare, basically. And whether it's Medicare Advantage or traditional Medicare, there's millions of people that are going to be on the Medicare rolls within the next few years that are not there now. It's growing by 10. The people above 65 grows by 10,000 per day. So very big numbers to take care of. And we need to do the best that we can as a society to try to ensure that we're delivering the care that people deserve and that we would want for ourselves. So it's not just medical care, I think, and that's one of the points that we've tried to make here. I think it's really, it takes, as Dr. Yagi said, it takes a village, but not only in the clinic, but obviously in the greater world as well, to try to deliver the kinds of care outcomes that we are looking to achieve.
So Dr. Yagi, from the provider side, and obviously you are a definite specialist for Parkinson's, are there concerns that you have that's presented by the healthcare system in general?
First and foremost, as a clinician trained in a subspecialty of movement disorders, there are many challenges, and I feel there are a lot of barriers to care. My goal, first and foremost, is to take care of my patients, make sure that we're doing the best thing for them at any given moment in their kind of trajectory, a natural progression of their disease, whether it be kind of early in their stage of Parkinson's disease or in the more advanced stages. And as was mentioned, having that care team approach is a challenge. having the properly trained individuals that then become our colleagues, that then become our teammates to take care of our patients. That is a huge challenge. I think our society is still, there's an unmet need to create that sort of approach. We talk about the interdisciplinary approach. I mean, I always imagine kind of in a utopian clinic where we have, you know, our meeting with our movement disorders doctors, just one part of the care team plan, right? We're just providing one part of that as a movement disorder specialist. But imagine if we had a geriatrician, we had a pharmacist, a social worker, and a psychiatrist, everybody, you know, we could have this sort of multidisciplinary approach to care. Our patient in the middle, that patient-centered approach is always ideal. That was something that I've always been wanting to create within our own institution, and I hope we continue to strive for. But that's a challenge, and that is an unmet need, creating that patient-centered approach to care. The second challenge is, of course, understanding how it is that we can utilize our medications to treat our symptoms, and then how do we improve that access of the medications so that our patients can then, from the time a prescriber writes the prescription, I know we don't write them as much anymore, we send them electronically, but so our patients aren't lost, because there's a huge kind of gap there, unmet need, and guiding our patient to be able to navigate, just to be able to obtain access to the prescription that we write. And then in many cases, there's a step beyond that and finding the right dose of those medications that are finally in our patient's hands. So it's not uncommon for us to sometimes have to what's called titrate to efficacy. So we have to sometimes start with a low dose and move slowly so that we do what's right, mitigate the risk for adverse events by starting at a low dose and finding that dose that works to alleviate symptoms. Sometimes just something as simple as that, titrating a dose slowly up, can be very challenging for getting approvals for medications for specific doses while we're trying to move our way up. Another challenge also, of course, is communication. That communication, that access to the healthcare team that our patients are sometimes often needing. Maybe our care model of, you know, I'll see you every 3 months is not the right care model for Parkinson's disease. Maybe we need more kind of longitudinal-like care. Maybe rather than see each other every 3 to 6 months, maybe we need to see each other maybe every 1 to 3 months, maybe not spending as much time per visit, but that kind of constant communication and contact in a field that a lot of the times we are titrating to the individual case. I think effectively we'd be more successful if we can have more touch points, more communication points with patients. That in and of itself is a challenge given the whole ecosystem in which we live from a clinical standpoint.
It almost seems to me that what you're talking is very patient-centric, and your titration process even becomes more complicated as the disease progresses even. It may not even be just, you know, the medication's not working or achieving the right, you know, the right level, right dosage level. It may actually just be disease progression. So the patient's progressing on to the different stages. Dr. Today Allen, you had a comment?
I was just going to add to, you know, one thought that I had while Dr. Yahi was talking about how can we interact with our patients on a more often basis, taking advantage of digital solutions. I know people historically might think, oh, the elderly population, they don't know how to use a phone, that you got to give them, you know, something like the cricket phones or something that is just to call on a phone. But let's not forget, you know, the iPhone came out 15 years ago. So people who are turning 65 today were 50, right? A lot. And my mom is 77 and during the pandemic downloaded her own app and met her doctor virtually on her own, set up her credit card and everything without my assistance. So it's important to not just, let's think about how can we use technology to engage with these patients, see how they're doing, do a symptom tracker, send them a HIPAA compliant survey. How are your symptoms this week? And if it triggers something, again, that actionable data, those patient reported outcomes, obtaining that, whether it's the pharmacist who's able to collect that and monitor it and then alert and collaborate with the provider when those things are happening, and perhaps maybe get that patient in sooner than every 3 months because we're seeing something happen. But being able to take advantage of some of the different technological advances that we have, especially not just the advances that we have, but the acceptance of these technological advancements. Everybody knows what a Zoom is, right? We're all on Zoom right now. Everybody knows what a Zoom is, and a lot of elderly people have also been on Zoom. So while not everybody is like that, and again, everybody consumes information in a different way, but it's important to think about these different modalities that we can communicate with patients, and to not just assume that because they're an elderly patient that they're not going to want to use any kind of digital technology or a cell phone or anything like that to be able to receive their care.
I agree. I think it's very important to try to optimize remote monitoring and other capabilities like that when it's available. Again, as you said, not everyone can access technology the same way, but as you indicated, many older adults, most actually now, are adept and are comfortable using electronic communications. Again, I think, and just to ask Dr. Yagi a question, just in terms of remote monitoring or remote capabilities and use of maybe other specialists like yourself, for example, that could be accessed by a primary care physician remotely to try to help solve problems. I mean, we're focused on, again, as where I am, we're focused very heavily on trying to look at alternative payment models and so on, try to optimize what we're able to provide, and also to try to enhance this focus on keeping the patient at the center, doing what matters to him or her in a quality perspective. And again, are there opportunities that you've been aware of, again, just to Dr. Yagi, that for Parkinson's disease utilize some of these capabilities in an innovative way?
Great, it's a great question, and I would say that too is an unmet need. In my subspecialty, part of what's been lacking is that sort of constant contact. It's very hard. Our patients oftentimes have small issues that can sometimes snowball, and so that communication with our healthcare team is very, very important. The way we've set things up in terms of remote monitoring or virtual care clinics, that sort of thing, didn't really kind of take off until the COVID pandemic in 2020.
Right.
So to answer your question, it's an unmet need. I think we do precisely need to do a better job in exactly what you're talking about. And maybe that's the type of conversation we need to be having, how to kind of create that sort of collaborative approach to care by utilizing technology, utilizing these sorts of ways of contacting each other, having collegial consults, even if they're virtual consults, having a conversation between our geriatrics department and our movement disorders department seems like a very fundamental task, and I'm not sure we do that enough. This is the fastest, or considered one of the fastest growing neurologic diseases, Parkinson's disease. And so it kind of fits right into your messaging, Dr. Spivak, that as we age, we'll continue to increase the number of patients that need a subspecialist for neurologic care or advanced age care. And so if we don't do a good job of creating this sort of collaborative care approach and keep the patient in the center, I think we're going to create more of an economic burden to the system as our patients continue to age.
Great. So as we take a look at this population, and we talked about the growing eligibility of this population in the Medicare system, and then we take a look at Parkinson's therapy being an integrated approach of the on therapy as well as the on-demand therapies. We also know that Medicare, there's a certain portion of Medicare that's under traditional Medicare where there may be a question of access to medications. Do you believe that there is a problem, or there is an issue or a barrier with access to medications for this portion of the Medicare population?
From a clinical standpoint, I can answer that question, and you're right. It's an important question to ask. There's many kind of layers to the answer, but generally speaking, what I can say is that from hearing just from a patient perspective in a clinic, when I'm seeing patients all week long, spending a long time with each patient, you know, it's hard for me as a clinician to understand what processes our patients need to go through in order to gain that access to care, right? Whether even when it comes to physical therapy, non-pharmacologic approaches, I maybe have had some training in my medical school, in my residency, maybe my subspecialty training, but it didn't prepare me for the non-clinical side of support. Like, how do I support my patient from a non-clinical side? I mean, I need a team. And what I can tell you is that over the past 5 years, since I've been a junior attending within an institution, it's been a very important part of our department and our subspecialty to be able to provide that support. So gaining a resource like a social worker became so important for our clinic to be able to help our patients with navigating some of those kind of insurance questions when it comes to what sort of physical therapy to get, where to do it in the home, in a center, how to gain access to some of these therapies, what sort of advocacy groups to learn about so that our patients can educate themselves, not just about therapies, but learn from the support group members about how to obtain some of these therapies. There are foundations that are available for a lot of our patients when it comes to helping them learn and gain resources and obtain medications. And so there are a lot of things in terms of resources that I don't think as a clinician I was equipped to be able to provide in terms of support. And so that kind of complex care model where we have an interdisciplinary team does become even more important, because the challenges beyond the clinical challenges oftentimes can outweigh the challenges of just our clinical analyses.
I don't think, I agree. I don't think there's any question that we can do better in terms of simplification of the system, right? We can certainly identify, each of us, I'm sure, a number of things that we would rather didn't exist, that make it more difficult for us to deliver or to be able to assure that our patients are getting the care that they require. There's no question about, whether it's access to medication, access to specialists like yourself, Dr. Yagi, or to pharmacy, geriatric pharmacists, as was mentioned, and others. There's a lot more that we can do better, no question. We're talking about, potentially, progressive conditions which are going to require a different approach in 6 months than they require today. Maybe it'll be a different approach in next week than they require today. And we need to be able to adjust and adapt and be flexible in terms of what we're able to assure that people can have access to. There's no question about that. And we're doing better, I think. There's a lot more that could be said for some of the health systems today than what may have existed some years ago. And I think, that's because people are demanding it, as well as I think we're learning that it improves the value that we deliver. Conditions don't get neglected. Issues don't get shoved under the table. And, we're trying to emphasize doing the right thing and trying to achieve what we and others typically consider high quality outcomes for this population, for those who have Parkinson's disease. Making sure that people are evaluated on a regular basis, maybe it's every year, to assure that we're paying attention to their medication management, to the role of psychological or psychiatric approaches, if need be, to the role of rehab approaches, to autonomic problems that may exist and complicate the management of their neurologic disorder, Parkinson's disease, whether it's urinary problems, constipation, gut problems, as had been mentioned earlier, and others, to try to avoid any difficulties that they may have in utilizing the medications that are proven to be effective for on-demand therapy. So that if they're on a medication that's also going to potentially lead to orthostasis or hypotension, or complicate the use of one of these potentially beneficial approaches, we should try to look at whether that really continues to be needed by that individual. So, not just in geriatric medicine, but in general, the focus really needs to be on assuring that the right medications are used, and that we've not only identified those that might need to be added, but that we've also looked at, could we maybe decrease the burden of medication by minimizing or eliminating those that no longer have a role or are not really providing benefit to that individual any longer. So I think it's, doing the job better, smarter, more efficiently. And again, can't emphasize enough, trying to assure that we're providing high value care, that we're doing what has been demonstrated by the medical evidence to work. I think, the list is, much longer now in terms of available approaches that are beneficial and proven to be beneficial than existed just a few years ago. And there's much more opportunity that we have to try to manage this condition much more effectively. We just need to be able to have the tools within our capability to be utilized effectively when they're needed. So there's no question that we can do better in terms of trying to simplify and improve the system that we have to manage this problem.
Dr. Today Allen, any thoughts on barriers to the effective management of the Parkinson's patient?
One of the barriers to kind of that effective is just understanding how to get the medication. So Dr. Yahi mentioned the approval process. If a patient walks into the pharmacy and the technician tells them, oh, no, we can't get your medicine, it needs a PA. A patient doesn't understand what a PA is. It's also training our staff to, how do you explain it to a patient? How do you put it in terms that a patient is going to understand? What is a prior authorization? Why might it be needed for this particular medication? Because just saying, oh, it's a prior authorization your doctor needs to do is not the way you answer that question, because then they go, but the doctor prescribed it. And so there's just all this back and forth, and it creates a lot of frustration in that patient, where then that patient starts to disengage themselves from healthcare, from their own healthcare. And so we really want to try and minimize that, make sure that we're explaining to them, helping them, again, navigate that benefit, understanding not just from a medication perspective, but they might need pre-approval for their physical therapy, or obviously they'll definitely need it for any kind of surgery. So being able to explain that to patients in a way that they're going to understand, and explain it to them more than one time. They're going to need to hear that more than one time. Repetition is something that is very necessary in these very complex care models that we have with Parkinson's disease. Another kind of barrier challenge is with some of these on-demand therapies, it's very counseling intensive. And I know that these tertiary centers are great centers, but not everyone has access to those tertiary centers, right? They physically can't go places, right? They may live in a rural area. They don't have the finances to be able to even drive, an hour perhaps to that location. So these are things that we need to think about. And then how do we help care for that patient? And again, the counseling on some of these on-demand therapies, like the inhaled levodopa product, or the injection, or even the sublingual apomorphine, we need to counsel that patient, not just the first time, but every time they're going to fill that medication, what worked but didn't work, help, and then teach back to me. It's not just, here's how you take it, but make sure, because they'll say, do you have any questions? Everybody's always going to say no. It's important for pharmacists when they're counseling patients to provide that information, not just assume that if they don't have any questions that they're good, they're fine. It's always important to check in with that patient to see how they're doing on the medication. Help me, to describe to me how you're taking the medication, because it sounds like patients are going to understand, but they don't. We live in this world of clinical stuff, and as clinicians, we think everybody understands everything all the time, but that's not reality, right? So these are some really important, and they're very nuanced, but it's important that there's a process in place, that there's strategies in place to make sure that we're communicating with those patients. And again, not every patient is going to absorb that information the same way. Some patients want it verbally and written. Some of them want you to send them a video. Some of them want you to provide some links with information that they can consume on their own, and then also share with their spouse or their caregiver, whoever might be helping them take care of their disease state. So there's a lot of challenges that I think if we try to just have one size fits all approach, it's never going to work. That is never going to be the way that we're going to be able to really help manage these patients. And ultimately, the reason we're doing this is to improve their quality of life. And it's not just their quality of care, it's their quality of life. How do we help improve these patients live these better lives and improve their quality of life from having this disease state?
Great. Dr. Yagi, do you have any closing thoughts?
Colleagues have said so many very important things on this panel. I've learned a lot, I've internalized a lot, and hearing their perspectives has been invaluable for me as a clinician. And I do believe that everyone here really has a perspective that can be very important, especially what I've heard is that communication and education, both of those things are probably kind of the best tools we might have to be able to help support and guide our patients. And so I think when it comes to diagnosing, when it comes to therapeutics, when it comes to non-pharmacologic approaches, all of these things, we try to utilize all of these things in tandem to better diagnose, treat, and care for our patients along the natural progression of Parkinson's disease. As was mentioned, Dr. Spivak said so well that basically when we see our aging population, we have to try our best to be able to, almost in a nimble fashion, evolve the way each encounter with our own patient is going to go. We kind of have to use some sorts of educational tools, as Dr. Today Allen on one visit, but later on, we may have to evolve and be a little nimble and start learning how to draw in kind of the other consultants that we need, the different subspecialties. So basically, when it comes to an advanced age patient, we have to really think about not just one thing. We can't keep our blinders on one thing. We have to continuously think about our analysis and our therapeutic landscape in a dynamic way that is going to constantly change. It's expected to constantly change. And we're going to utilize therapies and non-pharmacologic measures so that we can better treat each patient individually. And that's kind of how I would conclude. The message that resounded in me from everything that we talked about was that one. And if we don't work together, we are doing ourselves as a society a disservice. You know, we have to work together with all of these wonderful people on this panel. I've learned, you know, maybe this is the right way to do it, you know, having more conversations like this to instill hope, because that's another thing there's an unmet need in instilling this hope. Hope comes from our positive attitude, how it is that we try and think about the disease as a proactive. How can we proactively diagnose, proactively treat, and then plan for the future, create that support structure for advancing disease so that our patients are prepared to be able to tackle what comes next. And so I really think that this has been a positive and hopeful discussion. And I'm going to leave here feeling a lot better and happy, you know, that we had a wonderful discussion that I think we should have more of.
Dr. Spivak, closing thoughts?
Just to echo what Dr. Yagi had indicated, I think the important thing for us is to keep in mind the geriatric approach, which is the patient is at the center. And what we need to do is to try to focus on what means the most to that particular person. Trying to build the care team, trying to build the environment, trying to build the community supports and structure, whether it's home care, whether it's some other focus in terms of trying to optimize that individual's mobilization in their setting that improves their well-being, improves their quality of life. And again, not to forget about trying to have a handle on some of the quality measures, not just quality of care, as we often hear about, but as Dr. Today Allen said, quality of life measures. I think that's really the focus, should be the focus of what most older adults really want for themselves, and I think what most of us would want. Just a word or comment about prior authorization and some of the difficulties. Again, We've talked about some of the challenges, and I think these challenges are in the process of being improved upon. Prior authorization, I know from our perspective, can potentially create barriers, not only in terms of accessing medication, but accessing other treatments. We want to try to minimize that, not only because it causes delay in what may be beneficial and very effective therapy, but also because it leads to abrasion from the physicians who are prescribing and so on, and creates unnecessary barriers in the system. So there's a lot that's going on now to try to minimize or eliminate the prior authorization approaches, and try to ensure that when the prescription is generated in the office or in the clinic, wherever it's coming from by the prescriber, at that point in care, at that point of service, there should be some indication as to whether there will or won't be some other information that needs to be provided in order to ultimately have that medication become available for that particular patient. So that way there aren't the delays and the phone calls back and forth, or the faxing, or any other information that has to be transmitted to create a barrier in terms of having that person get the medication that may be needed for them. We're trying to make things easier, simpler, and more effective, and again, from the payer perspective. But we are aware of these challenges and so on, and certainly don't want to do anything that will unnecessarily delay what may be appropriate therapy. Again, I want to emphasize the proper approach, I think, in terms of the team-based approach. I think, as we've heard from everyone, the importance is to try to utilize available expertise to the best extent possible with the individuals that can provide the best input to ultimately manage and care for that individual most effectively. And it will hopefully lead to some innovative approaches, as we've talked about earlier on this call, and also enhance what we're able to do to make a difference in the lives of these individuals, as well as those who are caring for them.
And last but not least, Dr. Today Allen, what do you have any closing thoughts?
As we wrap up this great conversation that we've had today, and it's been a pleasure chatting with you all, and I know I'm also kind of inspired to set off some ideas in my head of what I want to do in my own practice, and what I want to try and do, and see how we can help improve patients' quality of life. When I think about Parkinson's disease, it's one of those disease states where it's very important that we can't just focus on the medication. I know that that's what we might think that's what we should be doing. We really need to think about, how is this medication impacting that patient's quality of life? Is the end result what that patient wants, to echo what Dr. Spivak was saying? But how do we know that, right? And so another thing that I'm really that I really want to leave this conversation with is that we need to harness technology better. Why are we not able to harness this technology that we are using in every other aspect? Every other industry exists, but not in healthcare, which makes no sense to me. And so, I implore any listeners out there, if you're one person, that doesn't mean you can't do something. Try and see if you can call a patient and get those patient-reported outcomes, even if it's just on the phone, right? Even if you're not able to connect with them from a technology perspective, being able to collect some of that patient-reported outcome and then act upon that, collect that information, put it as part of your clinical practice, integrate it into your visits, being able to collect that information. Because unless you're collecting the data, and then you can't just collect the data and do nothing with it. You have to collect the data and then be able to act upon that data that you're collecting, and then leveraging the technology. And we need to get, if this exists in your organization, disavow people from thinking that, oh, they're elderly people, they're never going to use a cell phone, they're never going to use a smartphone, they don't want to get text messages, they don't want to receive these kind of communications. That is not true. That is not reality. And so, think outside the box. Think about how can we best serve these patients, and where, like, some of these unmet needs, being able to understand how patients are responding to therapy, the difficulty in titration schedules. How do we educate patients? Maybe patients don't want someone talking to them. They would rather watch it on a video. Make a 5-minute video about how to administer and how to use those inhalation devices. Provide a curated list to those patients about, here's the right video to go see on YouTube about how to make sure you're using the if you're using the on-demand inhaled version. This is the best video that we've been able to find. And so those are all sorts of things that I want to kind of leave with, is that we need to take better advantage of technology. The Parkinson's disease is going to be getting more widespread. There's going to be more and more people who have Parkinson's disease, and we need more individuals who are trained and understand the disease state and how to help these patients, and not just in the disease state, but how to communicate with patients who are elderly. How do we make sure that we look at the whole holistic patient?
This concludes our 3-part roundtable series. Please be sure to view parts 1 and 2 of the series if you haven't already. Thank you to our faculty for your insights, and a special thanks to our sponsor, Synovian, and to First Report Managed Care for making this video possible.